years part 1. I am going to discuss a case of Hughes Mucinous cystidioma of ovary. A 55-year-old female patient, para 1, menopausal woman, came to OPD with a chief complaint of abdominal distension since 3 months and weight loss since 3 months. History of present illness. Patient was separately alright 3 months back. There is history of abdominal distension since 3 months, which is rapidly increasing in size without any aggravating or relieving factors. There is history of gradual loss of weight since 3 months. History of vague abdominal pain, which is diffuse, and history of loss of appetite. There is no history of constipation, diarrhea, vomiting, hematemesis, or melena. No history of frequency or difficulty in micturition. No history of fever, jaundice. Past medical history. No similar complaints in the past. Patient is unable to walk on the left leg since 20 years due to polio. No history of diabetes, hypertension, tuberculosis, bronchial asthma, or epilepsy. Past surgical history. Previous history of LSCS 16 years back. Personal history. Patient takes mixed diet. Her bowel and bladder habits are unaltered. No sleep disturbances, no addictions, no drug allergy. Menstrual history. She attained menopause 8 years back. Family history. No history of similar complaints in the family. Treatment history. Patient is not on any medications. On general examination, patient is conscious, coherent and cooperative, lean built and moderately nourished. Pale are present. There is no icterus, cyanosis, clubbing or generalized lymphadenopathy or edema. On CVS examination, pulse was 95 per minute regular. No special character. Blood pressure is 160 by 100 mm of mercury in the right upper limb in supine position. Heart sounds S1 S2 present, no murmurs. Respiratory system, rate was 16 per minute. Breath sounds bilateral NBBS heard. CNS examination, nothing abnormal detected. On examination of abdomen, inspection. Abdomen is convex and hugely distended, more on the left side. Umbilicus is shifted downwards and everted. Engorged veins visible over the anterior abdominal wall. Blood flow is away from the umbilicus. Skin over the abdomen is normal. Suprapubic transverse scar is seen. On palpation, there is no local rise of temperature or no tenderness present. Abdomen is tense. Fluid thrill is present. No shifting dullness. No organomegaly or no palpable lymph nodes. On percussion, there is dull note over the anterior abdomen and no shifting dullness. On auscultation, bowel sounds are not audible. Left supraclavicular nodes are not enlarged. On parietal examination, anterior and posterior skin tags are present. Sphincter tone is high. Rectum loaded with half fecal matter. No masses felt. On parvaginal examination, difficult to perform because of Hughes mass and patient is also not cooperative. Provisional diagnosis. Abdominal examination revealed Hughes pelvic abdominal mass from symphysis pubis to civisternum, maybe a pelvic tumor or a ovarian tumor. Differential diagnosis is retroperitoneal sarcoma or ascites. Ascites can be ruled out as there is no shifting dullness. Retroperitoneal sarcoma, because it is Hughes abdomen, as mostly Hughes abdomen lumps arise from the retroperitoneum. Investigations. Complete blood picture is normal. Her ESR was 31 mm per hour. Bleeding time, clotting time normal. On urine analysis, everything is normal, nothing abnormal. And serum CA125 level is 113 international units per ml. Liver function test and thyroid profile normal. Random blood sugar and all other investigations are normal. Chest X-ray, tracheal shift to right, elevated right hemidiaphragm. CP angle appears normal, lung parenchyma also appears normal. Abdominal sonography, Hughes mass with a predominant homogeneous echogenicity, echogenic internal septations, cystic mass scattered along the periphery occupying entire abdomen, maybe retroperitoneal sarcoma or ovarian tumor. On CECT abdomen, there is a Hughes voluminous, well-defined cystic mass lesion arising from the pelvis left side and extending up to the sternum, displacing bowel loops and mesentery posteriorly more towards left. Lesion having multiple thin septations with large and small cysts of different densities and with areas of necrosis. On CT abdomen, my conclusion was features suggestive of large mucinous cystadenoma, probably of left ovarian origin. This is the CT picture. Cytopathology, ovarian cyst fluid analysis showed degenerated cells and cyst macrophages against a mucoid background.